I'm pleased to be moderating this session. I'm very excited about this topic. I'm going to move through it pretty quickly, but this is the therapeutic potential and pain and PTSD, anxiety session. And I'm co-moderating with Susan Borja. I'll introduce the first two speakers, and Susan will introduce the second two. The first speaker today is Andrea Hohmann from Indiana University. Andrea is a Linda and Jack Gill Chair of Biomedical Science and Professor of Psychological and Brain Sciences at Indiana University. Her work has focused on harnessing the therapeutic potential of the brain's own cannabis-like system to suppress pain while minimizing the unwanted side effects. If you join me in welcoming Andrea.
Also, I want to mention that I have no financial disclosures. Cannabis has been used for medicinal purposes to treat pain since the beginning of recorded history. I'd like to start my talk today by describing the results of a behavioral study using animals. When you administer formalin to the hind paw of a rat, it produces pain behavior. This slide quantifies pain behavior following formalin administration in the paw in control animals and in animals that received a dose of a cannabinoid known as Win55212-2 or Win2. Note that the effect of the cannabinoid is to dose-dependently suppress pain-related behavior, and at the high dose, pain behavior was virtually eliminated. But there's a problem with this interpretation. This is what a rat on Win2 actually looks like. Now, the motor effects of cannabinoids, as we've heard from our previous speaker, are actually a very serious problem for behavioral studies, which largely rely upon assessing motor responses to noxious stimulation. So these types of studies alone aren't sufficient for us to conclude that cannabinoids suppress pain. To do that, it's really necessary to show that cannabinoids suppress nociceptive transmission. Now, Michael Walker's laboratory was the first to do this. Now, this slide summarizes some of the neural pathways that I'll be referring to. Notice that ascending pathways for the transmission of pain are shown in red, and descending pathways that serve to turn off or modulate pain are shown in blue. Now, pain is initiated when a subpopulation of neurons, the nociceptors, are activated by a noxious stimulus. And the nociceptors convey this information into pain processing regions in the spinal cord. Shown in red is the classical ascending pain pathway, the spinothalamic tract. Pain, however, is actively suppressed from descending projections that originate in the periaqueductal gray of the midbrain and the nucleus rhamphus magnus of the medulla, and these projections serve to turn off the transmission of impulses from nociceptors to the central nervous system. So an effect of a cannabinoid on the cells of the spinothalamic tract would provide a convincing argument that cannabinoids interrupt nociceptive transmission. We recorded from wide dynamic range neurons in the lumbar spinal cord that code information about stimulus intensity. Here you can see the effects of the cannabinoid agonist Win2, its inactive enantiomer Win3, and the vehicle control. Note that the effect of the cannabinoid is to suppress noxious stimulus-evoked neuronal activation, firing rate, in the wide dynamic range neurons. When we tested the effect of the high dose of the active compound on purely non-nociceptive neurons, no suppression was observed. So these observations are very important because they show that the effect of the cannabinoid was selected for the nociceptive neuron. Wide dynamic range neurons were suppressed by the cannabinoid, but purely non-nociceptive neurons were unaffected under the same conditions. Well, I've shown you some behavioral data which suggests that cannabinoids suppress pain, and I've shown you some electrophysiological data which suggests that cannabinoids suppress pain processing. If these effects are mediated by a common mechanism, it should be possible to show a correspondence between them. So we compared the ability of cannabinoids to suppress pain behavior in a test of antinociception with their ability to suppress noxious stimuli-evoked firing rates and wide dynamic range neurons. So as you can see, as the dose of the cannabinoid is increased, firing rate in the VPL neurons is suppressed and antinociception is enhanced. So the strong correlation between the behavioral and the electrophysiological measures suggests that cannabinoids do indeed suppress nociceptive transmission. Now I want to emphasize that cannabinoids have been shown to produce antinociception in virtually every animal model of pathological pain that has been tested. I'd also like to emphasize that the evidence which suggests that cannabinoids suppress pain is not merely based on behavioral studies, but also includes the results of neurochemical studies and neurophysiological studies. And that from these studies, we can conclude that both CB1 and CB2 receptor mechanisms suppress pain. Now, the studies using synthetic cannabinoids suggest that endocannabinoids suppress pain under physiological conditions. We've already heard a lot at this meeting about these two endocannabinoids, anandamide and 2-AG, which are the best studied of the endocannabinoids isolated so far. Anandamide is hydrolyzed by this enzyme, fatty acid amide hydrolase, into breakdown products arachidonic acid and ethanolamine. And indeed, FAAH inhibitors that are both brain penetrant and brain impenetrant have been developed and are an exciting possible target for drug development in industry. These FAAH inhibitors suppress pain primarily through CB1 mechanisms. Now, the mechanisms that are responsible for the formation of the endocannabinoid anandamide do remain incompletely understood. But by contrast, we know that 2-AG is produced on demand and acts as a retrograde endocannabinoid messenger to suppress pain, at least at the level of the periaqueductal gray. So in the periaqueductal gray, activation of metabotropic glutamate receptors by glutamate triggers the consecutive activation of two enzymes, phospholipase C-beta and diacylglycerol lipase alpha. This results in the formation of 2-AG in the postsynaptic neuron. Following its formation, 2-AG would then be released to engage presynaptic CB1 receptors. And as we heard yesterday, the net result of binding to CB1 is to turn off the release of the excitatory neurotransmitter from that presynaptic terminal. Now, following binding to CB1 receptors, 2-AG would then be deactivated, first by transport into cells, then by intracellular hydrolysis, which is catalyzed by a distinct enzyme, monoacylglycerol lipase. Now, multiple inhibitors of monoacylglycerol lipase have also been described, and they produce antinociception, primarily through CB1 and CB2 specific mechanisms. But I'd like to emphasize that these endocannabinoid deactivation inhibitors lack many of the untoward motor side effects associated with direct agonists such as Wnt2 or THC. So much of the research in the field has really focused on these two enzymes, FAAH and monoacylglycerol lipase, which degrade the endocannabinoids. However, it's very important to keep in mind that these enzymes are actually not selective for endocannabinoids. They degrade other lipids that do not actually bind to cannabinoid receptors. Moreover, it's probably also very important to keep in mind that in vivo, the enzymes that control the metabolism of endocannabinoids might not look very much like this at all, but they're probably much more likely to look like this. Now, this poses actually a considerable challenge for drug development efforts because we still need to know more about the conditions under which some of these other metabolic enzymes would be activated and engaged, and what the functional roles of some of these products of endocannabinoid metabolism really is. Now, CB1 receptor activation has many desirable therapeutic properties, including suppression of pain. The problem is that activation of these receptors also produces unwanted psychoactive effects and side effects that are undesirable in a therapeutic intervention. So the classical marijuana high. Thank you, Miles. Now, these observations have really prompted research efforts that were focused on separating therapeutic efficacy from unwanted CNS side effects. Now, one way this has been done in the pain field has been to target peripheral cannabinoid mechanisms that bypass the central nervous system or bypass CB1 receptors within the central nervous system. But I also want to emphasize that CB2 receptors are found primarily in immune tissues and immune cells, only at low levels in the CNS, but they may be induced in response to inflammation and injury. And so much research efforts have focused on harnessing the therapeutic potential of CB2 receptors for suppressing pain. Now, I'm going to use this molecule, CB55940, because it binds with equal affinity to both CB1 and CB2 receptors. And I'm going to use this to really reveal the functional roles of CB1 and CB2 in suppressing pain. Now, in all of the studies that I'm presenting here today, we're going to use animals that are in a neuropathic pain state to better increase translational relevance, because we're not just interested in efficacy, we're also interested in side effects, and we're also interested in abuse liability. So in these studies, we used a model of neuropathic pain that was produced by injection of the chemotherapeutic agent Paclitaxel. So notice that the effect of the chemotherapy is to produce a time-dependent lowering of the threshold for paw withdrawal to mechanical stimulation, which is consistent with the development of a mechanical allodynia, or hypersensitivity to pain. Now, if you give CB55940 to neuropathic animals that have received paclitaxel, you see unwanted side effects, or actually CB1-mediated pharmacological effects that are not desirable for a therapeutic intervention. Shown here, you can see that CB55940 produces a dose-dependent hypothermic effect. It also can produce motor impairment at higher doses. And these effects are CB1-mediated. Note that they're absent in the CB1 receptor knockout mouse. But fortunately, I'm going to tell you that with repeated administration, tolerance develops to these unwanted hypothermic effects of the cannabinoid. Unfortunately, I'm also going to tell you that tolerance developed to the therapeutic effects of this cannabinoid agonist. So notice CB55940 at a dose that engages CB1 receptors produced therapeutic efficacy and attenuated paclitaxel-induced neuropathic pain. But with repeated dosing, the cannabinoid no longer produced therapeutic efficacy. Again, the anti-allodynic effect was mediated by CB1 receptors because it was absent in the CB1 receptor knockout mice. Well, what about the potential for abuse liability? We address this question by taking our neuropathic animals that received chronic dosing with cannabinoids and then challenging them with a CB1 antagonist in an effort to precipitate a withdrawal syndrome. Notice that in animals that were chronically treated with the cannabinoid, shown here as CB55940, but we've seen the same results with THC, notice that we can unmask a withdrawal syndrome by challenging the animals with the CB1 antagonist. And this appears here as increases in paw tremors, head shakes, and scratching bouts. Notice that it's CB1-mediated because this pattern of behavior is absent in CB1 receptor knockout mice. Well, these studies suggest that activation of CB1 receptors has desirable therapeutic properties, including producing antinociception and suppressing neuropathic pain. But especially at higher doses, we also see hypothermia, motor impairment, and physical dependence. So we asked whether under conditions in which binding to cannabinoid CB1 receptors was eliminated, whether we could unmask CB2-mediated antinociceptive effects that were free of these unwanted pharmacological effects associated with CB1 receptors in the brain. So we did this using CB1 receptor knockout mice. Then we gave them the very same compound, CB55940, but at a higher dose to engage CB2 receptors. So under these conditions, I want to emphasize that using CB1 receptor knockout mice, the very same compound produces sustained therapeutic efficacy through a CB2 receptor mechanism. Note that this effect could be completely blocked by a CB2 antagonist, AM630, and that with sustained dosing, and we've done this in rodents for up to 4 weeks, we've seen no tolerance with repeated dosing via CB2 receptor mechanism. So these studies suggest that activation of CB2 receptors would be an exciting therapeutic target for drug development in industry for putative analgesics, particularly for neuropathic and inflammatory pain. And so we collaborated with the laboratory of Alex Macrianis to address this question, using selective CB2 agonists to produce a suppression of a neuropathic pain state. Notice that the compound AM1710 was able to basically completely reverse neuropathic pain in our animal model. And it did this again with sustained efficacy, with no tolerance, and with no signs of CB1 receptor activation, like hypothermia or motor impairment, or even physical dependence or tolerance. Notice also that the effects of the CB2 agonists were mediated by CB2 receptors because all of the efficacy disappeared in the CB2 receptor knockout mice. So we know that paclitaxel produces neuropathic pain, at least in part, by activating pro-inflammatory cytokines and chemokines in the central nervous system. So our studies and those of others in the literature suggest that activation of CB2 receptors can suppress pro-inflammatory cytokines and chemokines, thereby blunting neuropathic pain. And it can do this without producing hypothermia, motor impairment, physical dependence, or tolerance. Now, by contrast, THC, the orthosteric classical cannabinoid agonist, also suppresses neuropathic pain. But because it engages CB1 receptors in the CNS, it also produced hypothermia, motor impairment, physical dependence, and tolerance, effects that would be undesirable for a therapeutic intervention. So does this mean that CB1 receptors have no therapeutic potential for suppressing pain? Clearly, my view is that answer is no. We've already heard earlier in this meeting about the existence of an allosteric binding site on the G protein-coupled cannabinoid receptor. Ken Mackey described to us how binding of a positive allosteric modulator to this site has the result of increasing the affinity or the efficacy of the endogenous cannabinoid at that classical orthosteric binding site. So the net result of having the presence of that CB1 positive allosteric modulator on board is that we get boosted signaling downstream of binding to the G protein-coupled receptor. Moreover, we're also preserving the spatial and temporal pattern of endocannabinoid signaling, in contrast to flooding this whole system with a systemic administration of a global CB1 agonist. So here we compared the classical orthosteric cannabinoid agonist delta-9-THC with a CB1 positive allosteric modulator under identical conditions. Notice that THC initially suppresses neuropathic pain in our animal models, but with repeated dosing, we see complete tolerance developing to the therapeutic effects of THC. Notice also that tolerance develops much more rapidly to the high compared to the lower dose of THC. By contrast, work in Aaron Lichtman's laboratory and our own laboratories has suggested that CB1 positive allosteric modulators show sustained efficacy that is not subject to tolerance. Moreover, they also lack the unwanted effects of cannabinoids on motor activity and hypothermia. Well, these studies using delta-9-THC make us really think about what are the implications for use of cannabis and use of cannabinoid-based therapeutic interventions. But I want to emphasize that cannabis is not the same as delta-9-THC. We already heard at this meeting that cannabis contains about 400 active compounds. Many of them may have therapeutic benefit. And one of the compounds that we heard quite a lot about at this meeting yesterday was cannabidiol. Work by Sarah Jane Ward has examined the efficacy of cannabidiol in suppressing neuropathic pain in the same animal model that I've presented here today. Note that cannabidiol shows sustained therapeutic efficacy without tolerance, and this was observed over 21 days of repeated dosing. So these findings taken together should really suggest that perhaps if we combine THC with cannabidiol, we'll see a better therapeutic effect without tolerance. So we tested this in humans by collaborating with the laboratory of Mary Lynch to examine the effects of Sativex on chemotherapy-induced peripheral neuropathic pain. This was done in a double-blind placebo-controlled crossover trial. This was a pilot trial with Sativex, which is an oral mucosal spray which contains THC and cannabidiol in a 1-to-1 ratio. So half the patients obtained Sativex followed by placebo, and the other half obtained placebo followed by Sativex. The primary outcome measure was the numerical rating scale of pain intensity, with anchors of 0, no pain, and 10, pain as bad as you can imagine. So the results of this pilot study in the population of subjects evaluated as a whole can be shown here. There was no effect of Sativex compared to the placebo group. So what does this mean? Are we somehow lost in translation and there's a problem with translating the results from our preclinical studies in animals where these same compounds have shown therapeutic efficacy and moving them to the clinic? Well, I would argue that that answer is actually probably no, and that our animal models, I believe, are actually pretty good. Even within the same study, a responder analysis was able to detect a subset of patients that showed significant benefit of Sativex compared to the placebo arm of the same subjects. And this was with the numbers needed to treat that was approximately the same as gabapentin. So I'd also like to emphasize that if we compare the results of this pilot trial with what we see with published randomized controlled trials of cannabinoids in pain that I've recently reviewed with Ethan Russo, I'd like to call your attention not to the individual studies, but to the overwhelming amount of green on the slide. The shaded green cells show the clinical trials in which cannabinoids have shown efficacy for pain. The white cells show the trials in which the cannabinoid did not show efficacy, so it's not very good for postoperative pain. And the gray cell shows a study in which the cannabinoids did not improve pain, but they improved other parameters such as sleep, which are therapeutically useful. So where do we go from here? I think I'll conclude my talk now by summarizing a little bit about what we think we know. We know that cannabinoids suppress pain processing through CB1 and CB2 specific mechanisms. They do this through spinal, supraspinal, and peripheral mechanisms. And this conclusion is largely supported by behavioral, neurochemical, and neurophysiological studies. We know that cannabinoid CB2 mechanisms and potentially peripheral cannabinoid mechanisms may bypass unwanted centrally mediated side effects of global cannabinoid agonists. We also know that endocannabinoids suppress pain. Moreover, pain modulates the endocannabinoid system. 2-AG is a retrograde endocannabinoid messenger that is produced on demand to produce adaptive changes in pain responsiveness. We know that enzymes implicated in endocannabinoid deactivation remain exciting therapeutic targets. Allosteric modulators of CB1 signaling also suppress pain in preclinical studies, and cannabidiol, a phytocannabinoid, shows therapeutic potential. Moreover, the results of randomized controlled trials largely support efficacy of cannabinoids for suppressing neuropathic pain, although some adverse effects are also observed. What we still need to know, originally I had 4 slides for this, but I've tried to reduce it to 1 because I'm over time. I apologize to you all for that. We still need to know the best way to separate therapeutic efficacy of cannabinoids from unwanted side effects, and I've talked about a couple of approaches that we can take to consider that possibility. We also need to know what the signaling pathways are that are responsible for efficacy or unwanted pharmacological effects of cannabinoids. This may also help us understand why some cannabinoids might fail in clinical trials if they're not signaling through the right signal transduction pathways. We do need to know more about the therapeutic potential of brain permeant versus impermeant inhibitors of endocannabinoid deactivation, whether they produce desensitization or unwanted side effects. We still need to know the mechanism of action of cannabidiol, and so we can better understand its therapeutic potential. We need to know if CB1 PAMs will have superior therapeutic profiles compared to other cannabinoid-based therapeutics, and we need to improve translation of preclinical findings to clinical populations. We don't know what are the factors that distinguish responders from non-responders in clinical trials, whether it's differences in efficacy or unwanted side effects or even genetics. And I think that we should make an effort to better understand comorbid disease states, because right now, the patients that may receive the most benefit from cannabinoid-based therapeutics might be patients with post-traumatic stress disorder, depression, and chronic pain, but such patients would actually be excluded from clinical trials focused on a unitary dimension. And so now I'd like to acknowledge my collaborators and thank you very much for your attention.
Thank you, Andrea. Our next speaker is Dr. Barth Wilsey, who is an associate physician in the departments of psychiatry and anesthesiology at the University of California, San Diego. Dr. Wilsey is going to hopefully talk about his 2 published papers out of a number of manuscripts on clinical trials involving human laboratory experiences that have demonstrated the efficacy of smoked and vaporized cannabis in the treatment of neuropathic pain. Join me in welcoming Dr. Wilsey.
Thank you very much, and it certainly is an honor to be here today. My slides are going to come on. So I'm from UC San Diego, as was mentioned, and there I work in the UC Center for Medicinal Cannabis Research. This center came into being, after California Compassionate Use Act was passed by ballot initiative in 1996. 3 years later, the state legislature decided to fund medical marijuana research. And the next year, in August of 2000, the UC Center for Medicinal Cannabis was established. It was to have closed, but the sunset provision was removed in 2003, and it's still in existence, I'm happy to say. All of the medical schools in California were involved in numerous studies that were sponsored by the UC Center for Medicinal Cannabis Research. I'd like to mention 8 of those studies because they were clinical trials. 4 were done at UC San Diego. 3 of the 4 were on neuropathic pain, you might notice. Additional 4 studies were done in Northern California, 2 at UC San Francisco and 2 at UC Davis, where I worked until last year. And again, 3 of the 4 were on neuropathic pain. So there were 6 studies performed in the last decade on neuropathic pain, funded by the UC Center for Medicinal Cannabis Research, and all were congruent in the finding that neuropathic pain could be alleviated by cannabis. And why were these 6 investigations done? Well, it's probably because we have very limited treatment for neuropathic pain. Neuropathic pain are conditions like diabetic neuropathy, post-hepatic neuralgia, post-stroke pain, post-spinal cord injury pain. Only about 40 to 60% of patients obtain even partial relief of their pain. So clearly there was room for improvement. I would notice this in the pain clinic where people would say, "Doctor, thank you for these opioids, anticonvulsants, antidepressants, topical agents, but they don't work in me. I have to go over and go to a dispensary and get medical marijuana." So it became an opportunity for me to do a study with the UC Center for Medicinal Cannabis Research, and we did our first study and published this in the Journal of Pain in 2008, and we found that indeed the cannabis was efficacious in the alleviation of this pain. Now, we use 7% THC, 3.5% THC, and placebo THC in a crossover manner where we had 38 patients with a heterogeneous collection of the neuropathic pain states that I mentioned earlier come in, and over 6 hours, in this first study, we gave them a cumulative dosing. After taking baseline data, we gave them 2 puffs, measured puffs, the so-called Fulton puff procedure. At 120 minutes, we gave them 3 puffs, and then at 180 minutes, we gave them 4 puffs. And what you can see from this slide, I think, is that the active agents, that is the 7% and the 3.5%, are what I'll call equianalgesic. In other words, they brought the VAS scale down, the VAS scale being anchored at 0, no pain, 100, the most severe pain imaginable. They brought them down equally. However, the side effects were different. There were many more side effects, and I'll get into the side effects subsequently, but the side effects were very more severe with the 7%. So at the conclusion, we recommended, if you're going to try medical marijuana for neuropathic pain, perhaps you should do the 3.5%. We had the opportunity to do a second study sponsored by CMCR, and this is the same slide showing the VAS pain intensity. We abandoned the use of smoking. Instead, by this time, Donald Abrams at UCSF had shown that vaporized cannabis was as effective in the delivery of THC as smoking, so we used a vaporizer. And we also discarded the 7% because we knew that 3.5% was as effective. So instead of 7%, we brought aboard 1.29%. So we were going to see whether the 1.29, and frankly, I didn't expect it to work because hemp, which is non-psychoactive, is 1%. So it's barely more THC than hemp. So I had no thought that this was going to work. But lo and behold, we found that there was the same sort of result where the active medicines were equianalgesic. So we infer from this that why use 7%, why use 3.5%, why shouldn't patients just take 1.29% and not have as many psychoactive effects? And I'll show you the psychoactive effects in subsequent slides. We also did something a little bit differently here. We abandoned the cumulative dosing of 2 puffs, 3 puffs, 4 puffs. Instead, we had them take a fixed dose of 4 puffs at 60 minutes, and at 180 minutes, we had them take 4 to 8 puffs. We let the patient decide. We didn't want to give them the expectation that we knew what we were doing, because we didn't. So we let them decide. And we know from the psychiatric literature that the non-fixed dose is effective in reducing the placebo effect. So we did it this time. Well, let's look at the side effects, because that's very important. Now, we did the same measures of side effects in both studies. We measured about 10 or so psychoactive side effects, and this included feeling high, feeling impaired, feeling stoned, and this has been used repeatedly by numerous investigators, and it's shown to be a sensitive and reliable subjective measure of intoxication. And we gave them this at every hour, and this is just a representative sample of the side effects, and you'll see here, this is the line showing the 3.5%, and this was statistically significant than placebo. But the 1.29% was not, and it was just a bit more than placebo in at most hours. So we inferred that we could get away with not causing people to forget what they were saying in mid-sentence, which is kind of nice when you're 20, but when you're 60, it's not so nice anymore. So we showed that this was a good thing. The 1.29% was very effective in mediating or reducing the psychoactive effects. We also did neuropsychological testing. We looked at attention with the digit symbol modalities test, where people put a number below a symbol that's above, and they have a representative sample to pull from. But we do that with timing. We looked at memory, where we give them a list of 10 words and see if they can recall the words immediately, and then delayed recall after about 20 minutes. And we looked at fine motor coordination. This is done with a a pegboard test where they have to put a peg that has a little protuberance on it into a hole that fits the protuberance. And what we found here was, and I'll just summarize, this is rather busy, that for the pegboard, we did dominant and non-dominant hands. For the waist digit symbol test, the effect sizes were very small. None of them were above 0.4. However, as you've heard in earlier talks, learning and memory are problematic, and we saw that. And here I have outlined in red the effect sizes for the 3.53, and they're moderate effect sizes. But if we look at the next slide where we did the 1.29, the effect sizes are again small. So we found that this low dose could alleviate pain and had minimal psychoactive effects and had minimal effects on neuropsychological testing. Now, before we said, everybody do this, we have to stipulate that these were 2 6-hour laboratory experiments. And so we have to repeat this over 8-12 weeks to see if these doses remain effective. And we're going to start a trial later this summer in which we're going to attempt to do just that. There's a meta-analysis that was published last year by Peggy Whiting in JAMA that was concordant with what we found, what the investigators of CMCR found, and that moderate quality evidence existed to support the use of cannabinoids in chronic pain, and also in spasticity, according to this meta-analysis. There was lower quality evidence that cannabinoids were associated with improvements in nausea and vomiting due to chemotherapy, weight gain and HIV infection, sleep disorders, and Tourette syndrome. Now, I list all of the conditions that she reported, and you might note that chronic pain is at the top of the list with the most studies, randomized controlled trials, the most patients, followed closely by nausea and vomiting due to chemotherapy and spasticity due to multiple sclerosis and/or paraplegia. And that the other diseases have not been that well studied, particularly anxiety, in which there was only one study, glaucoma. You always hear that marijuana is good for glaucoma. There's only been one randomized controlled trial. And depression, there have been none. We also have survey data that supports the use of medical marijuana for pain. In a survey conducted at dispensaries in California by the chairman of UC Santa Cruz Department of Sociology, Craig Reinerman, he found that the complaints most often voiced by patients who were using medical marijuana, who were coming to the dispensaries, were pain, insomnia, and anxiety. And I think the last one is kind of interesting. You have people taking this for anxiety, and yet we're not studying it for anxiety. Likewise, a physician survey, when they asked physicians what they were prescribing medical marijuana for, most of them said pain and also muscle spasms. Also last year, there was a report on what happens or what are the effects over time. These are acute effects now, actually serious adverse events and adverse events. This was data from 7 pain clinics in Canada in which the patients received 12.5% THC over 1 year, and they collected data on the adverse events that occurred, and they used controls who were attending the same pain clinics, and they were not cannabis users. So it wasn't randomized, it wasn't blinded. But what they found in comparing the serious adverse events and the adverse events was that there was no increased risk of serious adverse events, which would be death or hospitalization. But there was a higher incidence rate of adverse events. And these, the authors noted, were nausea, somnolence, dizziness, headache, and nasopharyngitis, the most common adverse events. The median dose was 2.5 grams per day. I might mention this is like 2.5 NIDA cigarettes is my unit of measurement. And they also found that increasing the daily dose of cannabis did not lead to higher risks of serious adverse events or adverse events. So in other words, these patients were titrating it, the benefit obtained by using the cannabis with the adverse events. It was also interesting to note that there was a 30% dropout rate. So not everybody in a chronic pain clinic who is given cannabis is going to find it satisfactory. They dropped the use of cannabis for adverse events, perceived lack of efficacy, and or a dislike of the study product. That's what the authors said. I was interested to see whether or not they tabulated whether or not the people who dropped out did or did not have neuropathic pain, but that information wasn't there. I'm going to go into the knowledge gaps next, and the first one I'm going to mention is we still have never had a clinical trial looking at herbal cannabis with the 500 molecular constituents and oral pills like dronabinol. And so we should do this. What you hear anecdotally from patients, dronabinol has been on the market for 30 years, but it really has not, it's synthetic THC, it really has not replaced herbal cannabis in the minds of patients. They prefer the faster onset and shorter duration of action of the herbal product, allowing titration of the dose, presumably. But there has to be a double-blind comparison performed in the future, and this is what we're actually going to do. When I said we're going to look at an 8 to 12 week study later this year, we have NIDA funding to do a double-blind. Actually, there'd be double-blind, or a double placebo study, where we'll give dronabinol or placebo pill, vaporized cannabis or vaporized placebo, and we'll see whether dronabinol is as effective as herbal THC. Another gap, and we've heard a lot about cannabidiol, and we're very interested in doing that in the pain world. It's supposedly not psychoactive, although, and in fact, it may attenuate some of the psychoactive effects of cannabis, of THC, but that's not always the case. That's not always been found to be the case. But CBD has been well studied apart from THC. It's been thoroughly tested in humans, mainly in the form of Sativex, I would say. But NIDA, in its wisdom, is now going to make CBD available. This is a slide from the NIDA drug supply program, and they're going to allow us to look at low, which is less than 1%, medium 1 to 5%, high 5 to 10%, and very high, greater than 10%, concentrations of cannabidiol. For the most part, mixed with THC. If you wanted to just do THC, I don't believe you can do it. It has an orphan drug designation, so you have to pick a condition with less than 200,000 individuals in this country, and we don't have pain conditions that fit that description. That's what they're using for the catastrophic pediatric epilepsies. Another problem, something that we're going to try to tackle, is that there are recognizable side effects with cannabis. People don't think as well. They may find everything funny. And it might lead to poor concealment of group allocation. Let's say somebody enters our study and they've used cannabis before and they now have the belief, or they now associate, or they just have they're going to get better if they notice that they're thinking differently. And this is bad for the scientific integrity of these studies. We think that blinding is considered to be reserved when the accuracy of treatment guesses is no different than random guessing, estimated to be correct 50% of the time. And we've done this in our latest study, and we found that people could guess that they were getting active agents. So we've got to come up with ways to reduce this problem, and some of the methodologies that we're thinking of are to use an active placebo, something maybe like lorazepam, and to use an active comparator, where that comparator is known to be superior to placebo. Increasing the number of participants who respond to active medication has been done in psychiatric trials, and we might consider doing that in cannabis trials in the future, although that's rather expensive. And the thing that we've started doing already are the flexible dose design. While this doesn't do anything with masking, it reduces the participants' expectation of relief. Sorry about that. There's one more knowledge gap that I just want to go over, and that I think is very important in this day of inadvertent overdose from opioids. We'd like to know if cannabis can augment the analgesic effects of opioids. It is giving two addictive medicines to patients, but perhaps that's what we have to do in neuropathic pain. There's been one very nice study done by Donald Abrams at UCSF, where he put people in a closed unit for 5 days, and then he did an area under the curve for the opioids that they were taking. They were stable on either extended duration oxycodone or extended duration morphine. And he measured the area under the curve, as I said, before and after being on vaporized cannabis. And the plasma opioid levels did not change, so therefore there was no pharmacokinetic effect of cannabis with opioids. He did show, which intrigues me, is that the average pain reduction was 27% greater with the use of the vaporized cannabis in addition to the opioid. So that when you find a medicine that lets you reduce the amount of opioid you're giving a patient, that's a success. So I think that should be noted. And what I'd like to do is do this study that Dr. Abrams did, but he did it. He's a clinical pharmacologist as well as a hematologist oncologist. But I think it wasn't designed as an efficacy trial where you blind the patients to what they're receiving. So I'd like to repeat that and do that. I think it's become more imperative to look at the interaction of cannabis with opioids, particularly in light of this epidemiologic finding that in states in which medical cannabis is allowed, there's a lower state level of opioid overdose mortality rates. So I think that's a good hint that we should be looking at cannabis to maybe lower the dose of opioids that people are taking. I apologize for the slides jumping. So in summary, we know that cannabis is efficacious in the treatment of neuropathic pain. We know that chronic pain is a common indication for cannabis in surveys. We know that it has a reasonable safety profile, and I put the word acute in there because that doesn't mean that over time cannabis isn't going to lead to pulmonary problems. For instance, we know that there are bullae that develop in the apices of the lungs in people who smoke cannabis chronically. What we still need to know, as I mentioned earlier, are new ways of drug delivery other than smoking. What's the best way of doing this? What's the best combination of cannabinoids for analgesia? We certainly have no idea that, for instance, CBD, can you give it alone? And would it be effective for analgesia? Or what ratio of CBD to THC? And that's a good question. We want to make sure that we mask psychoactive effects somehow, some way. And we want to see if there's a synergistic interaction with opioids. I'm just going to acknowledge members of the University of California Center for Medicinal Cannabis Research, including the director, Igor Grant, Dr. Atkinson, Dr. Marcotte, who's here today, and the statistician who I've worked with, Rena Deutsch. And I also want to thank NIDA for supporting us, and particularly now the drug supply program. They've been very, very, very helpful in giving and letting us use the cannabis we want to use, the strains we want to use. Thank you very much.
Great. Well, thank you all. We're going to be moving into the second piece of this. I know we've been sitting for a while. If you want to stand up for a moment and stretch, but not leave unless you really have to. And in the interim, we're going to be doing a quick battery change so that we make sure that we have sound. And a quick announcement from building management here. There is a car in the garage with the lights on. And if your tag number happens to be Maryland 7BVE21, I was reluctant to say it's a green jaguar, which I'm not sure how many people are going to feel sympathetic about this, but it is. So just FYI, okay? Okay. Great. Okay, with that, I'm going to introduce Susan Borja from National Institute of Mental Health, who is going to facilitate the last two presentations of this scientific session on PTSD and anxiety. Is that right? Susan.
Thank you. I'm very excited to be here on behalf of NIMH. Our acting director, Bruce Cuthbert, will be here after lunch for some remarks, but right now we've got two great talks on PTSD and anxiety. First up is going to be Dr. Cecilia Hillard. She is a professor of pharmacology and toxicology and the director of the Neuroscience Research Center and associate dean of research at the Medical College of Wisconsin-Milwaukee. Dr. Hillard is also the executive director of the International Cannabinoid Research Society, which is a scientific organization devoted to dissemination and promotion of research regarding endocannabinoids and cannabinoids. Dr. Hillard is going to talk to us about using model animals with cannabinoids and the processing of fear and anxiety. Dr. Hillard.
Thank you, Susan, and I'd really like to thank the organizers for inviting me to participate in this really historic summit. It's been fascinating so far. So my task is to summarize the preclinical studies that demonstrate, I think, pretty clearly that the endocannabinoid signaling system is very involved in the processing of stress and fear and anxiety. So this is a kind of an old slide I've used for many, many years, demonstrating that the CNS has a job to interpret stimuli that the organism runs into in the course of its daily life, and interpret this in relationship to whether or not it's a threat, something we know about that is a threat, or something we don't really know about and could be a threat. And importantly, this the decision-making process does not occur in a vacuum. It's very much influenced by many of the things we've been hearing about in the last day or so. Developmental stage, gender, previous learning, individual life history. All of these are mixed together as the stimulus is interpreted by the CNS in relationship to its threat to the organism. So some of the responses that the animals will engage in include behavioral changes, as well as more physiologic changes, including the fight or flight response, the autonomic nervous system, also neuroendocrine changes such as activation of the HPA axis. So survival of the organism really depends on being able to detect these threats and appropriately respond to them. In an active manner, if the threat is really imminent and could hurt the organism. But in addition to responding in an active manner, there's also a problem when organisms over-respond to the stress. It's a little bit like the fireman who comes to put out a small fire and puts on so much water that now the person has a flood to mop up. And it's similar in responses to threats. When they're in balance, we have a good normal response. However, when the behavioral response is out of proportion to the stress, now we've got a problem with too much of the stress response. So endocannabinoids, acting primarily through CB1 receptors, which is what I'm going to focus on, are present in brain regions that we know are involved in the processing of these endocrine and behavioral responses to stress, anxiety, and fear. To sum up a lot of work, it is very clear that endocannabinoid CB1 receptor signaling links the stimulus input to the responses that occur. And it can modulate that degree of responding that I showed you in the last slide can be so vital in both directions so that we have enough but not too much responding. So these are some of the brain regions that are involved, showing their interconnections between each other. And there are strong cannabinoid receptor signals as well as the proteins involved in the synthesis and degradation of the endocannabinoids in every single one of these limbic brain regions. So I'm going to start by summarizing a little bit of the work that suggests that the endocannabinoid CB1 system is very important in regulation of the HPA axis response. So HPA stands for hypothalamic pituitary adrenal axis, and this is the classic endocrine response that is evoked by a stress or a threat. The cascade starts in the paraventricular nucleus of the hypothalamus, and cells that are designed to release the neuropeptide, corticotropin-releasing hormone, or CRH. It travels to the anterior pituitary, binds to receptors on pituitary cells that release adrenocorticotropic hormone, or ACTH, which travels in the circulation to the adrenal, where we release glucocorticoids. These glucocorticoids have widespread effects on the brain and body and are very important in some of the immune effects of stress as well as the behavioral changes. Importantly, the glucocorticoids come back up into the brain, and one of their jobs there is to say, okay, you can shut off the responding now through long and short feedback loops that come back to higher centers of the brain, to the PVN, and into the anterior pituitary to shut off further activation of the HPA axis. So on this side, I'm showing you that the cannabinoid receptors are found at every single level of the HPA axis. They're not very well studied in the anterior pituitary or the adrenal gland, but the fact that they link through inhibition of adenylate cyclase, and we know that both CRH and ACTH evoke the next step in the process through activation of adenylate cyclase, it really makes a lot of sense that they would be inhibitory to that activation process if they were turned on. In the paraventricular nucleus, we find cannabinoid receptors on both glutamatergic and GABAergic nerve terminals, and we've heard a couple times now that activation of these receptors will inhibit the neurotransmitters that are being produced. So here we have a little bit of a yin-yang going. We could either inhibit glutamate or GABA in the PVN. So it is very clear from much work that endocannabinoid CB1 receptor signal is part of the stress response. So in addition to evoking the HPA axis response, various molecules in that system also turn on endocannabinoid signaling. For the story with 2-AG is glucocorticoids. So there's evidence in multiple regions of the brain that express the glucocorticoid receptor GR, that activation of the glucocorticoid receptor will evoke the synthesis of 2-AG. So I'd like to add this to the list of things that we know can produce 2-AG to the list that Dr. Mackey presented to us yesterday. There's clear evidence that the glucocorticoid receptor also couples to the mobilization of 2-AG. Data for this is found in the hypothalamus by Jeff Tasker's lab. Brad Alger's shown it in the hippocampus. Our lab's shown it in the prefrontal cortex. And actually, Jeff had a very nice poster yesterday showing it also happens in the amygdala. The mechanism is really unclear, and I think one of the big open questions. It seems to be a membrane-associated glucocorticoid receptor. This isn't about the typical gene transcription effects that happen with GR activation. So what happens as a result is that in general it dampens HPA axis activation. In the PVN it seems to shut off that first step of activation, and within the prefrontal cortex and the hippocampus the story is more about glucocorticoid mediated feedback inhibition of the HPA axis. So we increase 2-AG up in the prefrontal cortex. It inhibits GABA release, which allows this neuron to fire. It couples to an inhibitory neuron, probably in the BNST, which inhibits further activation of the HPA axis. So a really beautiful, time delayed, because it's going to take a little while for CORT to get up into the PFC and produce this effect, but it's a feedback mechanism that requires 2-AG. Here's some of the data that loss of cannabinoid receptor signaling in the prefrontal cortex prolongs HPA axis activation following stress. These are data done with direct injection of a CB1 receptor antagonist into the PFC, done in rats, showing that if you induce stress, this is a restraint stress, 30 minutes later you have nice high circulating cort. In a vehicle-treated animal, this slowly decays away, but if you block the CB1 receptor, you block that loss of effect. No effect when it's injected into regions of the PFC that are not involved in this loop. These are studied in mice, showing again that systemic rimonabant does the same thing, and that CB1 receptor knockout mice also have a prolonged response to stress. There is also a very interesting role for anandamide in the amygdala in HPA axis regulation. So these are data done together with Matt Hill in our lab, showing that rats exposed to restraint stress exhibit a reduced concentration of anandamide in the basolateral amygdala that is inversely related to the amount of cort. So in other words, cort production, again in response to restraint, is highest when anandamide concentration is also the highest. So there's this negative correlation. We can affect the HPA axis activation by reducing the activation of Fa by a pharmacologic inhibitor. So stress together with URB, which is an antagonist or an inhibitor of Fa, produces a lower amount of cort, and this is reversed when the CB1 receptor blocker is also placed directly into the BLA. So Matt Hill's published some very nice work. I think this might be a little bit blurry, but he's got a beautiful story that the essential stress component that is activating this increase in Fa activity is actually CRH. So CRH rises in the amygdala as well as the PVN in response to stress, and through a mechanism likely involving some kind of kinase, Fa activity goes up, therefore you have less anandamide, therefore less CB1 receptor activation on glutamatergic terminals, and an increase in glutamate release and an activated amygdala. These taken together make us suggest that activation of Fa in the BLA seems to open a gate. So anandamide concentrations tend to be high at rest. During stress, Fa is activated, chews up all that anandamide, opens up the gate, which allows for glutamate to drive HPA axis activation. So it makes sense that blockade of Fa would inhibit this gate opening and reduce the HPA axis activation by stress. And this has been shown with pharmacologic effects. So one role of cannabinoid receptor signaling is to dampen HPA axis. It seems to reduce both the initiation of HPA axis by stress as well as be vital for efficient recovery of the HPA axis back to baseline after stress. So I want to move on now to anxiety behaviors. In rodents, we can measure anxiety by inferring their behavior in a maze called the elevated plus maze. This is a decision that the animal needs to make to go out onto these sort of scary open arms to explore them versus wanting to stay inside the dark enclosed arms where it's going to be safe. So we infer that the longer time animals spend on the open arms, the less anxious they feel because they're more exploratory. So these are data that our lab published 10 years ago now, showing that there must be some sort of tonic activation of the cannabinoid system that keeps animals less anxious. Because when we treat animals with the CB1 receptor antagonist AM251, we saw a reduction in the time spent in the open arm. So this suggests that animals are becoming more anxious, and of course we all recall that one of the side effects of the rimonabant use in humans was increase in anxiety, which really fits with these data. Interestingly, we set up our elevated plus maze with a lot of light shining on those open arms, so we had a very highly aversive environment, which is probably why we saw these effects, because Haller et al. Showed that they didn't see any effect of a difference between the CB1 knockout and wild type under low light conditions, but when they made their maze very anxious, they also saw that the CB1 knockout or loss of CB1 signaling reduced the time on the open arms. So this is one very interesting characteristic of the cannabinoid role here, which is that it kicks on in aversive conditions. So it's activated or important during stress, not during calm time periods. Sachin Patel published these data a couple of years ago, demonstrating that the concentrations of anandamide in the brain inversely correlate with anxiety. So the higher the anandamide concentration, the more the animals are likely to go into a light zone in a light dark box, and the more they're willing to sort of wander around in that part of the box. So these data suggest that stress suppresses brain anandamide. You can see here these are the stressed animals, lower anandamide overall and more anxious, and increases anxiety. And this very strong correlation would suggest that they have something to do with each other. On the other hand, potentiation of anandamide-mediated CB1 receptor activation reduces anxiety. So in this case, URB597, which is an inhibitor that was developed by the PMLE group, was used again by the Hillard group to demonstrate that in aversive conditions, again, we could promote time on the open arm when you block the activity of FA, suggesting that elevation of anandamide reduces anxiety. But again, he showed that this only occurred under aversive conditions. So once again, we have a system that requires stress in order to be kicked on. These are data that Matt and I did together using a FA knockout mouse together with chronic stress. So these were really stressed animals. They were restrained for 8 hours a day for a couple of weeks. And as a result of that chronic stress, we saw in animals a real reduction in time in the open, so the animals are quite anxious, but FA knockout animals are totally protected from this effect. Similarly, we could see that there was an increase in branching of amygdala neurons, which again is a classic sign of chronic stress. The amygdala is becoming far more important in the brain. That does not occur in the FA knockout mice. So together, these data really support the idea that inhibition of FA in particular will reverse this stress load on the behavioral response and normalize the behavioral response to match the threat, particularly when the anxiety is a result of chronic stress. So there are other ways that one can elevate CB1 receptor signaling. Of course, the second endocannabinoid 2-AG can be increased by inhibition of MAG lipase, and there are data that MAG lipase inhibitors do reduce anxiety in rats through cannabinoid receptors and oppose the pro-anxiety effects of chronic stress in mice. However, we also heard yesterday that MAG lipase can be a little tough to use because there's this problem of receptor desensitization. It really is a very strong agonist of the CB1 receptor, where anandamide with its partial agonist effects is more gentle. Direct agonists have long been known to produce biphasic effects in many behavioral paradigms, and this is essentially true with anxiety as well. So, for example, WIN 55212-2 at low doses produces an increase in time in the open, but once you get up to higher doses, now we see a reversal of that effect. So, beautiful data from using selective CB1 knockout mice by Beat Lutz has shown that it's probably receptors on glutamate versus GABA terminals that might be responsible for these biphasic effects. Phytocannabinoids, so THC, at least in mice, we never could find any anxiolytic effect or reduction in anxiety in THC-treated mice. However, in rats, one can see a reduction in anxiety at low doses. Cannabidiol, we've heard about many times. It actually reduces anxiety in rats very nicely under stressful conditions. It's probably a 5-HT1A mediated effect of CBD. Okay, a few words now about fear. So that was anxiety, which is really sort of the animal's perception that there might be something scary out there. Fear is really the behavioral response to something the animal knows is a danger. And it's very often studied in rodents using a process called cued fear conditioning. So in this process, an animal is put into a chamber, given a tone, and then followed by a foot shock. So this is done multiple times on the first day. And then you put the animal back into the process the next day in a procedure that's called extinction without the tone. And you can do that day after day after day, and slowly they will extinguish the memory of that aversive condition. And fear extinction is a place where cannabinoid signaling has been shown to be very involved. These data were published now 15 years ago or so by Beatlus and Giovanni Marsicano, showing that in CB1 receptor knockout mice, so here's the fear extinction curve in a wild-type mouse. So the first day they're freezing when they go into the chamber and hear the tone, but day after day, when the tone is not followed by a shock, they eventually relearn that it's now okay to be in there. That's called fear extinction. You can see that a CB1 knockout mouse really didn't extinguish the fear at all. And this is one of the hallmarks of PTSD, of course, is not being able to forget this aversive memory. And clearly, CB1 receptor signaling is important. There's less of an effect of the cannabinoid receptor on deletion on acquisition or consolidation of fear memories. Can we make this get better by activating CB1 receptor signaling? Yes, we can. These are data done by Andrew Holmes's group demonstrating that inhibition of FAW using yet another FAW inhibitor, AM3506, injected directly into the basolateral amygdala would reduce the freezing on retrieval, and this was reversed by a CB1 receptor antagonist, suggesting it's via CB1 receptors. So clearly, potentiation of anandamide signaling in the BLA does look like it would have some benefit in reducing, in enhancing extinction of fear. What about CB2? It looks like, again, CB2 is going to be a little tougher to work with because mice deficient in diacylglycerol, which remember is the enzyme that makes 2-AG, can't extinguish fear responses, so that fits with the idea that endocannabinoid signaling is required. However, mice treated with inhibitors of catabolism, so MAG lipase inhibitors, also exhibit increased expression of fear. So it looks like you have to have an optimal amount of 2-AG mediated signaling in order to have the proper amount of fear extinction. So I happen to think FAW and other manipulations that work on the anandamide side of the story are probably going to be easier to work with. So what we know is that CB1 receptor signaling is necessary for this appropriate response of the organism to stress and anxiety, and for appropriate extinction of aversive memories. And elevation of anandamide CB1 receptor signaling in particular will reduce HPA axis activation, reduces anxiety, and increases extinction, really placing it, I think, as a really nice target for treatment of anxiety and PTSD. Direct agonists and MAG lipase inhibition could do some of that, but we certainly have heard a lot about the side effects of direct agonists, and I think MAG lipase inhibition, with its ability to raise 2-AG and possibly desensitize CB1, could be tough. This is a concept that I think has not really been mentioned quite yet at this conference, which is the idea that there may be people who have various psychopathologies or who have chronic pain or other things because they have low endocannabinoid signaling for some reason. So Ethan Russo, I think, first suggested this general idea of a hypoendocannabinoergic system. So I think that one of the things we really need to still understand is, does hypocannabinoergic signaling, for one reason or another, either genetically, the CB1 receptor is not as good, or there's less endocannabinoid tone, is this part of the etiology of stress-induced anxiety and PTSD risk? Not everyone that's exposed to trauma gets PTSD. Is it that those that are exposed to trauma and have low endocannabinoid signaling are the most at risk for developing PTSD? And secondly, we heard earlier about personalized medicine and personalized approach. Andrea showed us data in the pain world suggesting that there could be a select population of individuals who are going to be very sensitive to elevation of endocannabinoid signaling. And I think this is a really big question, and I think one size is not going to fit all for treatment of anxiety and PTSD with an endocannabinoid manipulating drug as it isn't for many other drugs. So I'd like to see more evidence in animal models that might tease out, for example, animals that have had a lot prior stress, early life stress. Are they more sensitive to an endocannabinoid treatment to reduce anxiety and PTSD? So thank you for your attention.
That was a great talk. Thank you. Next up, in our final talk in this session on the therapeutic potential for PTSD and anxiety, I'd like to introduce Dr. Christine Rabinak. She is an assistant professor of pharmacy practice and pharmaceutical science in the Eugene Applebaum College of Pharmacy and Health Sciences and in psychiatry and behavioral neurosciences and translational neuroscience program in the School of Medicine at Wayne State University. That's a lot of titles. She's involved in several research projects, including investigations of the cannabinoid system as a potential pharmacological target for improving the learning that goes on in exposure-based therapies. Welcome, Christine.
Okay, thank you very much. Before I begin, I want to thank the NIH and its institutes for putting this together and inviting me here to speak with you today. And then also for all of you for sticking around and listening to kind of all of this exciting new stuff that's happening. So first I want to kind of frame anxiety and trauma-based disorders for you and kind of the way we think about them. So anxiety and trauma-related disorders are associated with excessive fear reactions, often triggered by specific objects or situations that in the absence of any actual danger, and often include an inability to extinguish learned fear. So my talk is going to be very similar in structure to Dr. Hillard's in that I'm going to start off with talking about using cannabinoids to alleviate symptoms of anxiety, and then I'm going to switch and think about, is there another way we can target the system to help people that suffer from anxiety and PTSD? And I'm going to focus on the fear extinction. Okay? So over the last 20 years, human neuroimaging has been a powerful tool used to identify brain regions and networks involved in fear and anxiety. What I'm showing you here on the left-hand side is a meta-analysis of neuroimaging studies in humans using tasks that involve negative stimuli. So this might be pictures of scenes, or it might be faces, emotional expressions of fear and anger, threatening stimuli. And what we see consistently being activated to these kinds of negative stimuli is the amygdala. And that's highlighted here kind of in this purple right there. And not surprisingly, in neuroimaging studies, this is also another meta-analysis from patients with PTSD, social anxiety, and specific phobia, is that there's hyperactivity in the amygdala to negative stimuli or these fearful faces. And so it's suggested that this exaggerated amygdala activity might underlie kind of the pathophysiology of anxiety. And so what's really nice about neuroimaging is that it gives us an opportunity to kind of look at the ways that psychoactive medications or drugs might be able to mediate amygdala responding or brain responding to threat and anxiety. So to kind of put this into perspective, I'm going to start with something that we know, an evidence-based treatment for anxiety and PTSD is serotonin selective reuptake inhibitors. These are anxiolytics, and they're FDA approved. And if you look at kind of how they might have their anxiolytic effect, here on the left-hand side is a study of an acute SSRI treatment in healthy participants who went into a fMRI and looked at fearful faces, angry faces, or happy faces, and neutral faces. And what you see is that typically what we would expect under placebo conditions, people show increased amygdala activation to fear faces. And this is down here in the bar graph, extracted parameter estimates from this beautiful red activation blob here. But under acute SSRI treatment, this same amygdala activation is actually attenuated by citalopram. So here we've linked, just in this one study, have linked the kind of given a mechanistic target for the effects of SSRIs in this amygdala responding to threat. And more recently, Luan Phan's group has done a 12-week SSRI treatment study in generalized social phobia, in which they did an fMRI scan to a emotional faces processing task in generalized social phobia, and then they did a 12-week treatment with an SSRI, and then brought the patients back and did the same task again in the fMRI. And what they saw here in red is the social anxiety group. This kind of brighter red is pre-treatment. They show an exaggerated amygdala response to threatening stimuli or threatening faces compared to a comparative healthy control group in this lime green here. They compared to them, they show a very exaggerated response. But after 12 weeks of treatment, this response is significantly attenuated. And this is also associated with anxiolytic effects or symptom improvement in these patients. So if we think about cannabinoids as an anxiolytic, a potential anxiolytic, can we take this kind of a model, these kinds of tasks, and can we see similar effects? Would, for instance, THC or cannabidiol or marijuana have these same effects? And interestingly, it is consistent. So here again, Luan Phan had a study where he brought in healthy recreational cannabis users who had, they did another faces emotion task. They were shown faces of fear, anger, and happy. And under placebo condition, they show amygdala activation here. But under THC, this was within subject design, so within the same people, there was no amygdala activation under THC. This is synthetic THC, oral dronabinol. It's 7.5 milligrams. It's the lowest dose shown to have subjective effects as well as alter amygdala reactivity to threatening stimuli. And this last figure here is just a comparison showing you amygdala activation is greater in placebo compared to THC. Similarly, in another study, if you give cannabidiol to healthy participants and they do a faces task, they show decreased amygdala reactivity to threatening faces compared to placebo. So this was basic evidence to kind of show us that cannabinoids could attenuate threat responding in the amygdala and really gives us a target or a mechanistic approach to looking at this. There is very limited data, but there is a study here looking at this in anxiety patients. So what I showed you is all healthy people, right? And that's not the problem. Healthy people aren't the problem, right? So here, if you give cannabidiol, not only do you see a decrease in anxiety, so this is again that visual analog mood scale here, and so pre-treatment, patients with social anxiety report high levels of anxiety or discomfort. And time zero is when they're administered the drug. And over the duration of 140 minutes, you see that cannabidiol is significantly decreasing anxiety compared to a placebo condition. And this is associated with decreased activation in the amygdala. And this is just a resting state. So this time we're not even activating amygdala with a threatening face. So just in basal conditions, we can alter amygdala reactivity. This is consistent with a resting state study in citalopram in patients, in that you see decreased activation in this limbic system in citalopram compared to placebo. So there's a lot of overlap between these two kinds of studies here, and it's very promising. We know that people who utilize cannabis for anxiety or PTSD report using it to decrease symptoms of anxiety, improve insomnia, improve mood, and so it seems to be very effective, right? Well, it's not entirely the case. So we heard in the last talk that THC, for instance, has biphasic effects. So while it can be anxiolytic, it can also be anxiogenic. So there are studies that have been conducted similar to Luan-Fan that have used higher doses of THC and not found any effects on amygdala responding, and actually found increases anxiety type responses. So it's complicated, like everything we've heard today and yesterday. So some really exciting things. This kind of goes related to the last talk that Dr. Hillard brought up about individual variability in this system and how it might be a risk factor for developing anxiety or stress. So these are two studies that are looking at a common variant in the Fa gene. So we assume that if they have this variant, they have less Fa and increased anandamide circulating in the system, which means potential for increased anandamide in the brain. Unfortunately, unlike rats, we can't really measure it directly in a human's brain yet. But so what we see here is that, again, to a task where we show threatening faces, we see in people that have this A variant, A carriers, they show a decrease in amygdala activation. These are healthy people to threatening faces that have this variant. And so, whereas the C homozygotes show an increase in amygdala activation. This study on the right-hand side is similar, only now it's showing you the amount of amygdala habituation to threatening faces. So the higher this bar, the more habituation or attenuation of amygdala activation. So again, replicated. And this is important that we're able to replicate these findings. So I want to give you a summary of just these first couple studies. What we know in humans, evidence-based, is not as much as we know preclinically. Okay? So what I showed you is basically what we know. So acute exogenous cannabinoids modulate amygdala reactivity to threat. Increased endocannabinoid signaling is associated with lower amygdala reactivity to threat. And something I didn't mention before, but there is a study that has looked at the Fa variant in PTSD and has found that that was associated with threat symptomology in PTSD. So the C allele variant, or the C homozygotes, was associated with increased re-experiencing symptoms in PTSD. But that's one study that's been happened so far. So what do we still need to know if we consider THC cannabinoids as a potential anxiolytic, just like SSRIs? Well, I think this first question is a really important one that we need to seriously think about, is how would long-term treatment with exogenous cannabinoids affect anxiety patients? The data that we have so far is just acute. We don't have a long-term clinical trial giving this repeatedly over and over again to people. And we heard in other talks that chronic use could lead to downregulation of CB1 receptors, which has been associated with a depression-like phenotype and increased risk for addiction. So I don't want to treat one problem and create another one, right? The second one, if people with a certain genotype in this Fa receptor, could we give a Fa inhibitor to restore low levels of anandamide back to normal, thus maybe hopefully alleviating some of these symptoms? We don't know. We haven't used the Fa inhibitor in patients yet. We don't have published data on that. And lastly, how might other cannabinoid compounds affect fear processing brain activation? Most of these studies are done with pure compounds of either cannabidiol or THC. We don't know about other effects of all the other things that might be going on in marijuana. So I'm going to switch now. You know, my issue with treating symptoms of anxiety is that it's not necessarily getting at some of the root problems with PTSD and anxiety, which is this inability to extinguish or inhibit fear responses. And treating just the symptoms of anxiety is really no different than an SSRI, right? We're just treating symptoms, but is it something that they have to do for the rest of their lives? They have to keep smoking every day? What I'm going to ask you to do is step out of the box with me and think about this, targeting the system in another way that hopefully will give patients control of their lives again. Isn't something that they have to depend on in order to feel better, but is very targeted, and there's some evidence for. So like I said, PTSD and anxiety disorders can be conceptualized as a failure to appropriately inhibit or extinguish fear. Primary behavioral treatment is exposure-based therapy. How does this work? Well, just like this cartoon. Here, Mrs. Snyder she's got a phobia, a specific phobia to thunderstorms. So what her therapist is doing is throwing lightning bolts at her over and over again without actually hitting her to try to reduce her fear of thunderstorms. And so while this might be a little exaggerated, this is basically how it works. We're trying to extinguish a fear response to cues that really they shouldn't be afraid of. Although in this case, she might want to be afraid of lightning bolts. Okay. So we can use Pavlovian fear extinction like was described in animals in humans to kind of model this type of learning and look at this underlying dysfunction in anxiety and PTSD. And this is an example from a collaborator of mine, Mohammed Malad, who really was critical in kind of creating this paradigm, translating it from animals to humans. And briefly, this is what we do. Day one, we do fear conditioning with people. We teach them that a particular color light is paired with a mild wrist shock. So what we measure as like a fear response, for example, in these studies is changes in skin conductance. And so that's basically like a sweating response in your fingers. So that's what we use as our index of fear. And so after repeated trials, people learn that, oh, when that blue light comes on, I'm going to get a shock. And so now that blue light takes on properties of the aversive stimulus, and people show increased skin conductance or conditioned responses, as shown down here in the schematic, to that cue, even before they know whether or not they're going to get shocked. We bring them back and we can do extinction learning. So now we're going to say, okay, listen, that light's okay. It doesn't mean something bad, so we're trying to teach a new association. This isn't unlearning of the first association. This is a new association. Early on, in extinction session, they show high levels of fear. But as we consistently and persistently show this light to them in the absence of anything bad happening, those fear responses go down or extinguish. And we can test how well this works by doing an extinction recall test at a later time point. And so we show them the cue again in the absence of anything bad happening, and we're basically asking, how are you going to respond? Is the fear memory going to win and you're going to show high fear, or are you going to show very good recall of extinction learning? And typically what we see is good extinction recall, low levels of fear in people. However, in pathology, in like PTSD, for instance, we don't see that. They show this kind of recovery of the fear response as if this session never happened. They can do the extinction learning within session just fine, but it's the maintenance of that. So it seems to be very specific to this recall process. And we know, and this was brought up before, by using this model in neuroimaging, we have been able to identify brain regions that are involved in this ability to recall the extinction memory process. And this primarily is the ventral medial prefrontal cortex, here shown in the sagittal slice from a human brain. This is important in cognition and fear extinction recall. And also the hippocampus, here in the green circle, in this coronal slice. This is important for long-term memory consolidation as well as fear extinction recall. And not surprisingly, people with PTSD have deficits in the ability to recall extinction as well as decreased activation in these brain regions compared to healthy controls or traumatized non-PTSD patients. So, based off of the animal literature that we just heard about with, using this to try to enhance fear extinction learning, I kind of was thinking about this like, well, maybe we can do this in people. Let's see what happens, right? If we can find an agent that reverses VMPFC or hippocampal dysfunction, maybe we can reverse that impairment in the ability to extinguish fear and actually make therapy better. So in 2013, the study came out, and we asked the basic question, can cannabinoids facilitate fear extinction in humans? So we had a hypothesis based largely off of the animal literature. This hadn't been done in humans before. So if we gave a pre-extinction administration of an acute dose of THC, we expected to facilitate extinction of conditioned fear responses compared to placebo. So in a double-blind, placebo-controlled study, what we did was a fear conditioning study, very similar to what I just described. Here we showed different colored squares paired with an aversive white noise burst. on day 1, fear acquisition. Day 2, we brought everybody back and we administered either low-dose THC, again, dronabinol at 7.5 milligrams, or placebo. And then 2 hours later, we did the extinction learning test. 24 hours after that, we brought everybody back and we did a recall test. And I want to note here that this is important, that THC was only given during extinction learning, not during the recall test. So what did we see? Well, during extinction, we saw no effect of THC on within-session learning. At early extinction, this is mean skin conductance response to the cue that was previously paired with the white noise. And we see high levels of fear in both THC and placebo. And by the end of the session, both of those levels are low and there's no significant difference. If we look at this trial by trial, there's no difference in the rate of extinction. So THC is on board, but it's not actually interfering with this learning process or enhancing it. And I want to note, too, that we, like in the pain studies, we take a lot of measurements about subjective effects and do you feel anything? And most people that receive the THC assume that they're on placebo. So it's a very low dose and they don't really feel any subjective effects. And these aren't necessarily people that have used cannabis before. So some of these people are naive to it. There was only one person that received placebo that thought he was on THC, and it was a really uncomfortable debriefing, unblinding of him. So what do we see during recall? Well, we saw something really exciting. We saw something that was consistent with the animal literature. In those people that had received THC during extinction learning, we saw decreased skin conductance response to the cue that was extinguished compared to people that received placebo. They showed some spontaneous recovery of fear. So from this study, we had concluded that participants that received placebo during extinction learning exhibited spontaneous recovery of fear to a condition cue that was previously extinguished, whereas THC attenuated this response. THC didn't affect within-session learning, but it only influenced the ability to successfully recall extinction memory when compared to placebo, suggesting that THC affects the ability to maintain and/or successfully retrieve extinction memory. So we had kind of broadly concluded from this pre-extinction administration of an acute dose of THC facilitates extinction of conditioned fear in humans. What does it do to the underlying neural circuitry? We replicated this study in a separate group of people in the fMRI scanner this time. And what we found was that people that had received THC during extinction learning, during the recall test, showed increased activation in the VMPFC and the hippocampus compared to those that had received placebo. So this here, we had concluded that pre-extinction administration of THC modulates underlying neural circuits involved in fear extinction in humans. We were very excited about this data because this shows some promise for us. And just another thing really quick is that individual variability in that FA gene in just healthy, non-pathological psychiatric conditions influences the ability to learn this extinction or acquire this. So people with that CC homozygotes here, they show poor extinction recall. And people with a variant in the cannabinoid type 1 receptor also show poor or don't even extinguish. So this could influence their ability to respond to the treatment. So to summarize, I just have 2 slides. What we know from this study is that pre-extinction administration of THC facilitates extinction of conditioned fear in humans. It modulates the underlying neural circuits involved in fear extinction in humans. Individual variability in ECB signaling is associated with fear extinction learning success. So what do we still need to know? So can we rescue behavioral and neural deficits of fear extinction recall in PTSD anxiety disorder with an acute dose of THC? I'm doing that right now. I don't have results to say which way it's going to be going, but we have a funded study for that. So hopefully in the next year I'll be able to tell you. 2, what other cannabinoid targets could facilitate extinction? So we've heard that perhaps direct activation with THC might not be the best choice, and because of its psychoactive properties, could be difficult to work with. So there are FA inhibitors, there's Cannabidiol. I haven't worked with those yet because I haven't been able to access them. So hopefully that will change. And then lastly, can cannabinoids facilitate extinction-based exposure therapies? And hopefully, if this is funded, I will be able to tell you about that as well. So we will be taking this to a clinical trial. So what are some things that we still need to know? Long-term impact. What's the optimal dosing and timing of treatment? And then is there a therapeutic potential of cannabinoids for anxiety treatment in children? Anxiety treatment in children with pharmacological agents is very touchy in that we get increased suicide rates. And so this would be great if it could be another option, but as we've heard already, there are a lot of things to consider. So I just want to acknowledge our funding sources and all of my collaborators and my research staff who is key in collecting this data. Thank you.
So we're going to get all of the speakers up to the stage. Thank you for that talk, Dr. Rabinak. That was great. So we can start off with a question from, I'm getting it on the screen, but not up there, from Twitter. Okay, we'll read it. Oh, there we go. So this is to Dr. Hohmann. There are many CB1 and CB2 receptors in human skin. Do you believe topicals have a place in localized pain relief? Something pain relief? Localized, that's where we're all going to go with? Okay.
Yes, there's good evidence for peripheral cannabinoid antinociceptive mechanisms. I think that some topical products are still under development. I don't recall seeing much in terms of published clinical studies or clinical trials to see efficacy, but I think there's therapeutic potential that should be evaluated.
Another one for Dr. Hohmann. What were the characteristics of the subjects that responded to Sabrex within the pilot and with chemotherapy?
Yes. That's actually a really good question, and unfortunately I don't have an answer for that question because this was a pilot trial and a small number of subjects. The subjects differed on many parameters. They had different chemotherapeutic agents. They had different histories of prior medication for chemotherapy-induced peripheral neuropathy. Also, it's very important to point out that in a study like that, you're basically recruiting subjects who have not received benefit from other therapies. So it's a very difficult population to even see efficacy in. So we just don't know at this point.
Okay. Dr. Wilsey, sorry. As we re-examine the use of opioids for the treatment of chronic pain, there's an increase in the use of cannabinoids. Do we know enough about the side effects, potential impairment, drug interactions, and long-term effects of cannabinoid treatments to move forward so quickly?
I don't think we know enough. I think there has to be more investigation. We've prepared a cannabis use agreement, or similar to an opioid use agreement that has been in play in many pain clinics for years, telling people the side effects of cannabis, and advocating the lowest dose, advocating that they consider getting a mixture of a high ratio of CBD to THC. This is conjectural on our part to have said this, but hopefully there'll be more evidence coming out how to reduce the psychoactivity and the neurocognitive deficits that are produced by cannabis. You know, it's the problem with opioids, as you know, is that there's this inadvertent overdose from opioids, and that's because the opioid receptors are in the midbrain near the respiratory center, whereas cannabis doesn't have any cannabinoid receptors there. And I think that's why we've had this stage now where we've usually had just a recommendation to use cannabis, and we allow people to go to a dispensary and have somebody behind the counter recommend some ridiculous combination. We've got to learn more so that we can actually prescribe it. And I'm not saying that I'm sure it's going to be FDA approved. There are only two herbal medicines that are FDA approved currently that I read in Dr. Volka's blog. But I think there'll be interest, especially when cannabis is no longer Schedule I, with pharmaceutical companies coming into the fray. I've heard that from representatives of the pharmaceutical industry. So I think the future's there, but again, this comes with the warning that the side effects may be prohibitive.
Thanks. Another question from Twitter. Dr. Hillard, do you know about the mechanism that causes paranoia in some individuals when they smoke cannabis?
Yeah, that's a really good question. There certainly are biphasic effects of cannabis smoking, such that in naive users or in users who are exposed to very high amounts, and this turns out to be particularly problematic in oral cannabis use because the onset of action takes a while. Someone eats half of the cookie or brownie and says, I'm not feeling anything, and then eats the other half and winds up feeling very badly. So there can be pretty strong psychological changes that are associated with paranoia. Very much the opposite of kind of what we normally consider to be the anti-anxiety and reduction of fear effects of the cannabinoids. I think there's multiple explanations for this. One is that, as we've heard, the cannabinoid receptors are on both GABAergic and glutamatergic terminals. And just to think of this in a very simplistic way, glutamate is pushing on the accelerator and GABA is pushing on the brake. So if we're modulating both of these by flooding the brain with an agonist, who knows what's going to win in the end. And clearly the ability to engage receptors on glutamate versus GABA terminals is very much dose related. So as you get to very high doses of THC, you tend to produce effects that are much more dysphoric than one gets at low doses. So the mechanism is all the same. It probably is all CB1 receptors. It's likely a differentiation in the site in the circuit perhaps, or the cell, the neuron, the excitatory versus inhibitory neurons that are being hit by that drug at that concentration and dose.
Dr. Rabinak, quality exposure therapy requires attention be directed to the fear stimulus. How might THC's negative effects on attention impact exposure therapy?
That is a great question. So one idea of why exposure works is that you want to elicit the maximum amount of anxiety that the patient can withstand without bailing from the treatment. And you slowly work up a fear hierarchy from there. And so we don't really want to mess with their ability to feel those anxiety type symptoms. So, one idea, and I don't know if this is quite the answer you're looking for, but is trying to utilize a very low dose of THC, or maybe not even going the THC route, going one of these other routes instead, to kind of not interfere with the process of the exposure therapy. If it does and they can't attend to it, they're not going to see the benefit from the therapy. Yeah.
For both pain and PTSD, has there been any study across the lifespan about how the therapeutic effects may differ in young children, teens, adults, and then older adults?
Not that I'm aware of.
No, I'm not sure it's even been done in animals. Certainly hasn't been done in humans.
Is there an epigenetic modulation of CNRI in animals under stress?
Great question. As far as I know, there's no evidence as yet, at least not published evidence of an epigenetic change.
One final question for Dr. Hohmann. Does Sativex produce any side effects on rodent models and humans? Does Sativex produce any side effects in rodent models and humans?
Well, we're using the side effects that are observable and measurable in animals, such as motor impairment, hypothermia, ataxia, tail flick antinociception as signs of CB1 activation. And those are parameters that are easy to measure in animals. Of course, side effects in humans are more profound in terms of the psychoactivity or dizziness, and it's harder to measure that in animals.
Great.
but that's also CB1 mediated.
Great, and we're going to have one more question from Twitter. Can we compare SAE of opioids to that of cannabinoids through existing separate studies? Can we compare SAE of opioids to that of cannabinoids through existing separate studies? Significant adverse effects, I think. Yeah.
Well, sure. I mean, opioids can produce, or maybe, Barth, if you want to tackle this one, but opioids can produce very serious side effects. I mean, obviously, respiratory depression and lethality can occur, undesirable for therapeutic intervention. Constipation is nearly universal. Tolerance, opioid-induced hyperalgesia, and of course, physical dependence. And so I think cannabinoids, even by contrast, if you look at withdrawal from opioids compared to withdrawal from cannabinoids, the cannabinoid withdrawal syndrome is milder, clearly, and it lacks a lot of those pronounced autonomic signs, at least what we see. So I would think that the serious adverse events are even greater for opioids.
Yeah, I'm not sure I can compare them. I mentioned that study by Mark Ware in Canada that over 200 patients who were on cannabis didn't have increased incidence of serious adverse events compared to the control patients, the people who were not on cannabis. I would remark that in the case of opioids, numerous opioids have undergone FDA approval. So they have numerous studies involving administration over 8 to 12 weeks. Now we know that people have inadvertent overdoses, and there's certain reasons for that. If somebody has a history of addiction, if somebody has a serious psychiatric illness, they're more likely to have a inadvertent overdose. But in the studies that were done before this became apparent, before inadvertent overdose became more problematic in terms of fatalities than motor vehicle accidents in this country, we had a lot of studies that involved FDA approvals on opioids, and I didn't see this problem. In fact, during my 20-year career in pain medicine, I was not aware of this problem until Pelosi at the CDC discovered the overdosing was now from opioids. So that's not that recent, but I was kind of shocked. They're not that safe. In fact, the CDC is now saying, at least to primary care doctors, try to use physical therapy and cognitive behavioral therapy and try to avoid opioids. In my experience, that's been difficult because insurance companies won't pay for physical therapy and cognitive behavioral therapy. So the CDC director is trying to change that, and I hope he does. I still see that, I've watched the pendulum swing from when I was a medical student, when we wouldn't give an opioid to a young woman dying of cervical cancer because she might develop tolerance to it and might need it later. That's a true story 40 years ago. And then the pendulum swung during the 80s and 90s where we were giving it out like holy water in the pain clinic. And now we're back to being very careful with whom we're giving it, trying to choose patients who don't have, as I said, histories of addiction or histories of serious medical, psychiatric illnesses, and watching people more closely, doing urine toxicology screens, doing these surveys that we give that point out a propensity to abuse opioids. But I think there's always going to be a place for opioids, and now I'm hoping that cannabinoids can be used in conjunction. I can see somebody, we've been talking about PTSD here, I can see rational therapy where somebody with PTSD might use cannabis just in the evening to help treat their insomnia, help them forget. What medicine is there better than an opioid, than a cannabis to forget something?
I'd like to thank everybody on our panel and turn it over to Dr. Stein for announcements about lunch.
Great. Thank you, panelists. Same routine for lunch. We'll be back here at 1 o'clock. We have a terrific session on policy research, and we'll be followed by the new commissioner of the FDA joining us. So please come back.